Welcome to this historic moment, the first ever IWMF global webinar with support group breakouts. With over 400 registrants from around the world, I hope that you can all feel the power of our strong worldwide WM community connection. Can you feel it? I really can today. And I want to wish a huge thank you to the volunteer leaders who are responsible for creating today's program. The IWMF Support Group Leadership Committee is made up of, and please wave when I say your name, Steve Pine, who had this vision and brought it to fruition, Sharon Piotrowski, Sharon Rivet, Eileen Sullivan, Meg Mangan, and Jean Baptiste. Heartfelt thanks to Shelley Postic, IWMF Director of Information and Support, for spearheading and managing this program, and to the entire IWMF Rockstar team we have here today, Donna, wave Donna, and Robin, and Anne, and Cindy here with us. Let's show them some love. Mwah, mwah, mwah. And thanks to all of you for joining us today. You are in for a real treat. First, we're going to enjoy a 1-hour conversation with the incomparable Dr. Jorge Castillo of Dana-Farber Cancer Institute. And then we will be sending you all to smaller breakout groups for a support group experience. The good news is this is all going to happen automatically. You don't need to do a thing. Just note that the chat function in Zoom will only be available during the smaller breakout portion of this call. Now, over 70 of your thoughtful questions were pre-submitted for today's webinar. Now, we wish that we could get to all of them, but we appreciate your understanding in our time limitation because we have to return Dr. Castillo to his beautiful family by Thanksgiving. I now have the sheer joy of introducing you all to the newest IWMF rockstar on the block. It is my honor to warmly welcome Delora Seneff, the new president and CEO of the IWMF. Delora has spent over a decade in key roles supporting cancer research and patient advocacy. She is masterful at building strong relationships, promoting powerful partnerships, and managing complex cancer organizations with signature sensitivity and intentionality. So she has mad skills, we know that. But to me, the most important thing about Delora is that she leads with her whole heart. Delora's deep commitment to advancing cancer research and empowering informed patients is very personal. After losing her beloved brother to cancer, she made a promise to help support other families who know the pain of loss and who dare to dream of a cure. With deepest respect and excitement, please join me in welcoming Delora with a silent cheer so that she can say a few words to us to kick off this exciting program. Hi, Delora.
Hi, Lisa, and thank you so much. Very sweet of you. I appreciate that, and it's truly my honor and privilege to be here. So, as you shared, I'm the newest on the block. I officially joined in July. I started onboarding in July. Officially started in August. And as Lisa said, after spending a little over a decade focused on cancer research and advocacy, and like many of you, it's so personal and really finding purpose for the pain that my family and I went through. I've had the privilege over the last 45 days meeting people all over the world who have been affected by WM. Every one of those stories reminds me of why we exist. We're a community built by patients, for patients, and every step we take is powered by personal urgency and hope. And I take that very seriously. Looking forward to 2026 with our new research agenda. We're going to be focusing on funding top research centers, setting very clear goals so we can discover more quickly and deliver better treatments for all of you as fast as we can. And just as importantly, we'll continue to power the essential member services that so many of our community rely on. I'd like to thank our member service team, our support group leaders, and Dr. Castillo for making today possible. What an incredible opportunity, just to echo what Lisa said, for our community to come together in this setting. And a special note of gratitude for Shelley and her continued leadership, putting our patients at the center. What a gift to our organization. During my next 45 days, I will be popping into support groups, so don't be surprised if you see my face. And it's really just to say hello and listen to ensure that everyone's collective voice is heard as we look at our go-forward strategy. And if I don't see you in the support groups, I look forward to seeing you at one of our Ed Forums in 2026. So our European Ed Forum will be in Athens on April 24th. And then our North American Ed Forum will take place on May 1st in Columbus, Ohio. And I hope to see you at one, both, or in one of the meetings. And please always feel free to reach out if you have any questions in the meantime. And with that, I will hand it back to you, Lisa. Thank you.
Thank you so much, Delora. We're so thrilled that you are here. We're grateful for your inspiring leadership. Well, guys, I now have the most unnecessary, useless, silly task to perform. I am supposed to introduce you to someone who needs absolutely no introduction whatsoever, because he is part of our WM family. He is right here in the WM kitchen with us all, standing beside us as we each stir our own WM pot. But he adds in his special ingredients of the warmest bedside manner, the most helpful responses to our questions, the most generous gift of his time to the IWMF and to all of us, and the biggest, most caring heart that holds every patient's well-being with true compassion and with pure grace. So, if you're going to host a first ever global webinar with support group breakouts, who are you going to call? It is my delight and privilege to introduce the WM rockstar doc who needs no introduction whatsoever, Dr. Jorge Castillo at Dana-Farber Cancer Institute. I now turn it over to Jean Baptiste to begin a cozy fireside chat with our beloved rockstar doc.
Hello, everybody, and greetings from Washington, D.C. My name is Jean Baptiste, and I was diagnosed with WM May 9th of 2024. So a relative newbie, and I'm on watch and wait. Dr. Castillo, it's great to see you again. I did get a chance to see you from afar at the Ed Forum last year, or earlier this year. And I look forward to future opportunities to speak with you in person. Here's the first question. Can you share a bit of your journey from Peru to Mexico City and then on to Dana-Farber?
Yeah, no, thanks, Jean. Very nice to see you. And really, I would like to thank everybody for this amazing opportunity to be able to just, chat and talk about Waldenstroms, in this setting. I think is a very nice endeavor, and I'm happy that you guys thought about me for this specific, event. So, if I knew it was going to be a fireside, I'd have room with my bathrobe and my pipe. But I don't think I can do that in this setting. It's a fire hazard. So so about my journey, I would say that journey was done on the back of a donkey. Yeah. So when I was in Mexico, I used to work in a very rural. After I graduated, I worked for about a year or so in a very rural area in Mexico. And yeah, I had to go in and see patients, on donkey back. To go and see patients and vaccinate and, take care of people. And then I went back to Peru, to my home country, and I worked there for about 3 years. And yeah, I did a plenty of horseback and donkey back riding, on the mountains of Peru to provide care to these impoverished populations, provide some type of, help in some way. And if you have told me 25 years ago when I was riding that horse, that I would be here doing what I do, I would have laughed very loudly. It would have been an impossible dream for me to be where I am. So I really thank the many horseback and donkey back rides that I did in my time. because that actually is what brought me here up to some degree. So yes, I mean, I worked as a physician in Mexico and then in Peru. And at that time, I really was thinking already that I wanted to come to the United States to become a physician. At that time, I didn't know I wanted to do hematology. I was actually thinking more about taking care of patients with infectious diseases and things of that nature. But then, this faithful rotation with a hematologist, rest in peace, Dr. Marvin Adner, the Framingham Union Hospital, that really lured me into hematology. And from then on, I ended up at Brown University doing my training. I really honed my interest into hematologic problems, blood cancers specifically. And then, I met Steve Trion, a match made in heaven. And that was about 12 years ago. And for the last 12 years, I dedicated my life to Waldenstrom's macroglobulinemia.
Thank you. So there's this saying, it's not which treatment you choose, but which treatment to choose first. Could you elaborate on that, please?
Thanks. Yeah, I use that message a lot in my practice. And I want to be very clear about this. I do believe clinical trials, are very important to treat patients with any disease. And Waldenstrom's obviously is a very specific condition in which I think clinical trials are key. Having said all that, there are standard therapies, and the standard therapies that we have at this time can be divided broadly into two categories, which is the chemotherapy option and the non-chemotherapy option. And if you have seen what happens in other, blood conditions in which these two options are, also available, there are a lot of studies that have compared these treatments, using randomized studies and things of that nature. In Waldenstrom's is more challenging. It's a more rare population, and we don't have that extensive research done in that manner. So it's very difficult for me, to tell to any patient, oh, chemotherapy is better or non-chemotherapy is better. I don't think one of them is particularly better than another. There's a better fit to a patient, and that's why it's important for me to talk to the patients and see what the goals of treatment is, what other conditions they do have, what the genomic makeup of their malignant cells are. So there's a lot of other different features that we ask patients about, and we try to get a sense of patients, their preferences. And with that, we actually tailor treatment options to patients. But I do mean it, when we compare our experience, at least in terms of treatment efficacy between chemotherapeutic options and non-chemotherapeutic options, the markers or the outcomes that we see in patients are very similar. So, even though there are treatments that are given very differently and they do very different things to the patient's malignant cells, what the patients experience in terms of the benefits are actually very similar. So if you are not going to be in a clinical trial, and most patients will not be in a clinical trial, you can choose chemotherapy first and non-chemotherapy later, or you can choose non-chemotherapy first or chemotherapy later. So if you live long enough and you have this disease will at some point show up its head again, we might choose the other treatment at some point. So bottom line, you don't have to choose what to use first. You don't have to treat what to choose, but rather what to choose first, because more likely than not, these two are so effective regimens for Waldenstrom's that at some point one of the other will be used.
Mm-hmm. That's helpful. Is there a percentage of bone marrow involvement that distinguishes WM from MGUS? Patients are actually reporting having both diagnoses. Is that possible?
Well, yes and no. And I think the reason for that is because there are two classifications of subclassifications between MGUS and Waldenstrom's, depending if you use the international workshop criteria or the Mayo Clinic criteria. If you use the international workshop criteria, which is what we tend to use at Dana-Farber, we do not require a minimum of percentage of involvement to call, to label somebody as Waldenstrom's macroglobulinemia, as long as there's an excess of a lymphoplasmacytic population of those cells in the marrow. That could be a 1% or higher than that. That's enough for us to call it Waldenstrom's. For the Mayo Clinic criteria, you need to have at least a 10% of the bone marrow involved to be labeled as Waldenstrom's. So if you have one of the patients who have a 5% involvement, if you come to Dana-Farber and other centers who go by the workshop criteria, then you will be labeled as Waldenstrom's. But if you go to the Mayo Clinic and you are not at the 10% level, you will be labeled as MCAS, right? We're still trying to, reconcile, I would say, those two aspects of the classification of the disease. We do have specific beliefs, that support that the percentage, actually the percentage to label somebody Waldenstrom's should not be or at the 10%. But again, that is just criteria that people use for classification purposes. From my perspective, if somebody's asymptomatic, it doesn't really matter much, right? If somebody has MGUS or Waldenstrom's, or what the percentage is exactly, 5 versus 10. If somebody's clearly symptomatic, that shouldn't matter either, right? So at the end of the day, I think numbers are important to guide some treatment decisions and classifications and things of that nature. But treatment initiation and how the patient feels, to me, still is the most important thing in terms of making decisions in terms of therapy.
Here's another question about numbers. Many patients and some oncologists fixate on the IgM level. I will admit to being one of those patients. How do you advise your patients on what blood test results they should actually be monitoring, whether or not there are symptoms?
Yeah, that's a good point. And so when you come to Dana-Farber, this is just the experience at Dana-Farber. The average IgM in this clinic is about 4,000. That's the average. And I do have some colleagues of mine who say, tell the patients, if your IgM goes over 5,000, we will treat you. Or if your IgM goes over 4,500, we will treat you. We at Dana-Farber try not to use numbers, hardcore numbers, to make decisions in terms of how to treat. Unless the numbers are way too extreme, in which we think, clinically speaking, is a dangerous place to be. And typically that is, at least in our distribution curve, or the 5,000 patients we have seen over the last 2 decades at Dana-Farber, I think the top 5% will be well over 7,000. So at this time, that's the number that we're using. But again, that is only in a situation in which the patients are totally asymptomatic, everything else looks perfect, and the only issue is the IgM. The treating just purely based on IgM, and we looked at this in our database, is a rarity. The large majority of patients are being treated based on symptoms. Now, if you have come to my clinic, you will know that what we always say is that there's no correlation between the percentage of disease in the marrow and the IgM levels. We have patients with very little disease in the marrow, a lot of IgM, or a lot of disease in the marrow, very little IgM. So that correlation is not perfect. But despite the fact that it's not perfect, in between patients, within the same patients, I think it's very helpful to actually, measuring the IgM levels, and that will give us a sense if there is a disease stability or disease progression or response to treatment based on that. Because the default after an IgM, will be a bone marrow biopsy. And I don't think we should be doing bone marrow biopsies serially just to see, how the disease is going. If we can use a surrogate marker, in this case IgM, though imperfect, I think it's probably the best marker that we have. Besides the IgM, then we tend to use blood counts. Anemia is probably the most common manifestation of Waldenstrom's, and so we do follow the hemoglobin levels as time goes by. In some patients, it will be the platelets, the main markers. So every patient is just a little bit different, as you know. In some patients, the free light chains are important. In some patients, most patients are not, but in some patients there is. In some patients, the kidney function will be important, even though it's a very rare complication of Waldenstrom's. So I think once you go and see your Waldenstrom specialist, and then your history and your disease is kind of seen over time, that's where I think the importance of which numbers to follow becomes much more evident.
Mm-hmm. That's helpful. One of the things we really appreciate you, Dr. Castillo, is your transparency and honesty. And that's a setup for perhaps a controversial question that I have for you. We've heard a lot about functional cure and complete remission. It actually came up at the Ed Forum in Florida earlier this year. What do you call it when patients are between treatments? And what do you call it if there's no detectable disease after treatment?
Yeah. Yeah, that's interesting. So I think it's important to understand that there are two different ways to approach the care of patients with Waldenstrom's, and one of them is the clinical care, the care that is provided standard by physicians in the clinic, and the care that we provide to patients in clinical trials. Yeah. So I want to just focus on the standard of care first. In standard of care, the goal of the treatment is to make the patients feel well again, right? That's the main goal, and that could be bringing the IgM levels by 50%, and that would be good enough for the patient's hemoglobin to go from 8 to 14, and they feel great, and that will be a successful treatment, even though the patient's IgM has not gone away or normalized, for example. So the goal of treatment in the standard of care setting is to improve the patient's quality of life. And that could be the anemia or lymphadenopathy or spleen or enlargement of spleen of organs or some other problems. So now when we classify the responses to treatment, and that has to do with the depth of the response, how low the IgM goes, we take the baseline IgM and then we see what the treatment does to the IgM levels. And if the IgM goes down by 25%, we call it a minor response. If it goes down by 50%, we call it a partial response. And if it goes down by 90%, we call it a very good partial response. In some patients, the IgM normalizes, but still the electrophoresis, which is an additional test that we do sometimes, can show still a detectable, IgM abnormality. Those patients are still called very good partial responses, but only when the IgM is normal, the blood counts are normal, the electrophoresis doesn't detect this microscopic IgM, and the bone marrow biopsy is clean of disease. That's when we call or claim complete responses. Now, the goal of getting to complete response is not an active goal when we take care of patients in clinical care. In clinical trials, we're always trying to push a little bit of the envelope, and we know that complete remission or complete responses are rare, in currently with the current regimens, standard regimens in patients with Waldenstrom's. So in the newest generation of clinical trials, some of them pretty much driven by the WMNet and the network that we are working, with the foundation in many centers around the country. We have been able to develop clinical trials with the goal of deepening the response to see if we can get to complete responses, right? But that is a clinical trial objective. That is not a clinical care objective. So I want to make that difference. I agree that most patients will feel great if their IgMs will back down to normal, right? But again, that is not the goal of the standard of care at this time. So if, and what we have seen in other conditions like myeloma, for example, or chronic lymphocytic leukemia, which are conditions that are very close to Waldenstrom's, we do see complete remissions there at a much higher level than what we see in Waldenstrom's. So obviously, as a clinical trialist and somebody who takes care of patients with Waldenstrom's, I'm a little bit jealous, right? So can we generate treatment options that can get patients to complete remission, and what does that mean to patients? So that is an ongoing research question that we are trying to address. Again, in clinical trials, and therefore we can go after that. So if you get a treatment and your disease gets to a very good response, we call it, there is a deep response, and that's where the patients are. So we don't call that a remission per se. Mm-hmm. The word remission, we will use it only in the context of a complete response, which again, still is very rare in Waldenstrom's.
It seems as though complete response is more understandable than remission. Many of us will remember when we were first diagnosed, we were told it was rare and it's incurable. So that seems to make a lot of sense. I understand you have a new member of the team at the Bing Center. Can you tell us about the new team member?
Well, up and coming. So as you know, I started in the clinic about 12 years ago, and then we have my junior colleague Shayna Saroshek, who started about 5-6 years ago. So yeah, we keep growing, and we do have Dr. Camille Edwards, who has formally accepted the position of physician at the Bing Center for Waldenstrom's, who will start, I think, sometime in December. So mm-hmm. Yeah, that's going to be our new addition. She was still working at Boston Medical Center, and will be joining us very soon. She is very energetic, and I think the community will be very happy with her joining our forces.
Well, we look forward to meeting her, perhaps at an Ed Forum. What about a current recommendation you have for using Paxlovid for COVID and WM patients?
Yeah, so I mean, obviously that has evolved over time, and again, what we do in our clinic might not reflect what is being done in other clinics. So I want to be very sure that what I'm telling you is essentially our perspective, and other physicians can have other perspectives, and that doesn't mean they are wrong or that we are wrong or we are right. So I want to just clarify that. The way we are working that out in our clinic currently is based on the patient's symptoms and how severe the patient's symptoms are. Overall, if the symptoms tend to be mild, just like a common cold or things of that nature, we prefer patients not to be exposed to Paxlovid, because Paxlovid is a great medication, but it has its own side effects as well. However, if the symptoms are moderate to severe, high fevers, decreased oxygenation, loss of shortness of breath, or very bad cough, I think in that context, taking Paxlovid is reasonable, so it can help clear the viral load faster. If the symptoms are severe to the point that patients cannot take care of themselves, please go to the emergency room and be seen there, and maybe they will give you Paxlovid there. Now, that might be a little bit different in patients who are on active chemotherapy, for example, or patients who are considered to be more severely immunosuppressed, in which even patients with mild symptoms, might benefit from Paxlovid therapy. So again, I don't think there's a one-size-fits-all type of recommendation, but that's typically what we tend to use to make to treat that.
Thank you. It was an honor. Thank you very much, and I'm going to now pass it on to Sharon.
Thanks, Gene.
Thank you, Gene. Hello, Dr. Castillo. Nice to see you. So I am Sharon Rivet from Albany, New York, and I was diagnosed in 2018 and currently on active monitoring. So, Dr. Castillo, we know that you are a clinician, but you also do research. Could you talk a little bit about how you balance that and what are some of your challenges?
Well, plenty of that. So, yeah, I mean, when I was doing my fellowship, I really got interested in research, and I started doing a master's in clinical research at Brown University when I was a fellow, or actually when I was a junior faculty. And that really got me into clinical trial design and development. I started looking at different places to be able to, kind of use that expertise, those skills that I acquired. And I think joining the Dana-Farber at that time, that was in that juncture that I actually joined Dana-Farber. So it was the perfect environment. I mean, this is, I believe, the perfect environment to run clinical trials. It's a rare condition, and we are a center that attracts a substantial number of patients from outside of New England and within New England as well. So that really gives us a good opportunity to provide newer treatments to patients, and at least newer options to patients. I mean, the challenges I would say are a few, right? And that come from the patient's rarity, number one. Number two is patients, to participate in clinical trials, they have to go to the center where the research is being done. And that might be easier for some people, might be more challenging for some other patients, right? So just access to clinical trials. And then, our clinical trials are pretty much science-based. So we use a lot the data that comes from the research laboratory that is led by Stephen Trion, and to try to understand the biology of the disease and how we can, with some intelligence, try to develop new treatments based on that, what we learn from that. But not all the medications that we think will be helpful, or not all the companies are interested in running trials in those specific agents in patients with a rare disease, because at the end of the day, it's a business for them, and it needs to have a business plan from their perspective that makes sense. So yeah, so another challenge is sometimes we would love to have a specific compound to be, to try patients with Waldenstrom's, but sometimes that is not something that is in the company's, let's say, portfolio or interest, right? So there are a number of different challenges along the way. Thankfully, none of that has stopped us for continue running clinical trials. And now with the creation of the network, We're trying to run clinical trials at multiple centers in the United States at the same time. And you will be seeing the fruits of that very, very shortly with presentations and that we will have at national conferences.
Great. Thank you. You mentioned about how we are all very different with our WM. We said we're kind of like snowflakes, but how important is it for us as patients to be involved, not only in what we need to monitor test-wise, but also in the decision-making?
Yeah, I think it's key. Most of you who have been in my clinic, I keep telling you, you and your family are your best own advocates. You will know more about your disease than most of the doctors you will meet in your lifetime. And that's why, our role as Waldenstrom specialists is to be there in your corner to try to support that. Everybody's different. Everybody reacts to different treatments in different ways, and individuals can have either very rare manifestations of the disease or very rare complications of the treatments, and it's important that you are heard by your local physicians and your local doctors when you are having a problem, right? And if we can help in any way, you know that you can email me, call me, and if you're my patient, and I'll be happy to talk to any doctor to try to explain that how something that might not make sense in their minds, it does make sense from the Waldenstrom perspective. So I think it's important as a patient to be educated. I think it's important as a patient to have your loved ones and your close ones in kind of involved in your care, to work as a team. I think that really helps a lot, and to have a physician or physicians also who are there to listen to you and to help you, right? So I think that's the best combination of the best team you can have to help you in your journey.
Questions have come up what are the treatments that are currently available if you've been through BNR and you've been through BTK inhibitors? What's the next line of treatment?
Good, that's a great question. Chemoimmunotherapy, let's put it this way, has been around for quite some time. It's a very effective regimen, as I mentioned earlier. And the other non-chemo approach is these BTK inhibitors. Now, BTK inhibitors, there are two types, and we have the older type. Now it's called older. It's called covalent BTK inhibitors, and those are the ones that we use in the clinic routinely. We have a new generation of BTK inhibitors, non-covalent BTK inhibitors, and there's a new medication in that family that seems to work even when the covalent BTK inhibitors do not work anymore. So when you are in a covalent BTK inhibitor like ibrutinib, acalabrutinib, or zanubrutinib, and the medication stops working, more likely no other covalent inhibitor is going to help in that setting, but the non-covalent can. So a non-covalent BTK inhibitor, in this case pirtobrutinib, is a potential treatment option. The standard option is FDA approved for chronic lymphocytic leukemia and endorsed by the National Guidelines Committee with the NCCN guidelines. So we use pirtobrutinib in this type of patients very often. The other option will be a different type of targeted agents that it targets a pathway called BCL2. BCL2 is a survival pathway that these cancer cells use, and there's a medication called venetoclax that can be used in that setting as well. So pirtobrutinib or venetoclax. There is another group of medications, kind of older medications that we use for myeloma called proteasome inhibitors. And there are three of them in the market now: bortezomib, carfilzomib, ixazomib. I think those are potential options as well that patients could potentially get treated with. And all these are standard treatment options, that patients can use. And there are a few other options that tend to be, in our experience, are more toxic and less effective. Some patients can get rituximab alone, for example, or get other medications. But those, in our minds, I think those three are the treatments that most patients in the third line probably will get exposed to or should get exposed to. Yeah, unless there's a clinical trial available in that setting, and there's a slew of clinical trials actually available in that setting for patients who have already been exposed to BTK inhibitors and rituximab-containing regimens. We do have a study that is using antibody drug conjugates, like loncastuximab tesirine. That's a new type of medication approved already for other conditions, but is now being tried in Waldenstrom's. There's a group of medications called bispecific antibodies, and there's a study that we just opened using one of these. All these are agents that have actually revolutionized the treatment of other lymphomas, and we're trying to use them in Waldenstrom's. These are the first time we're using these type of agents in Waldenstrom's, and thankfully, lots of these studies are being open in multiple centers across the country through the network and other institutions. There's a new class of BTK targeting agents called BTK degraders that also are pills, and they seem to be effective even when the non-covalent and the covalent don't already work. So BTK degraders is another option. And there's a second generation BCL2 inhibitors like sonrotoclax that also. So there's plenty of options out there, and there's many others, coming down the road, either targeted agents or immunotherapies. And what is coming next, I believe, is what we call cellular therapies, right? CAR T cells. We're under conversations with a couple of different companies who might be interested on actually pursuing the dream of opening a CAR T cell program for Waldenstrom's in the near future. So again, as you can see, plenty of options. And I think that is actually a good thing for patients with Waldenstrom's.
To follow up on this, because we see this question a lot on our Facebook page, people are often asked how often can they repeat chemotherapy treatment?
Yeah, that's a good question. Chemotherapy is a great treatment, and it's just that it has a very small side effect that could be problematic to some individuals, and that is the small risk of having myeloid neoplasms. What that means is the mechanism of action of chemotherapy is like bendamustine, cyclophosphamide, fludarabine, and things like that. It goes in the malignant cells inside the nucleus of the malignant cells and causes some mutations in the genes of the cancer cells, and that's how it kills the cancer cells. So it's a mechanism of action, and it's very effective. But it can also cause some mutations in the normal cells, and that sometimes can give way to conditions like myelodysplasia, which is a pre-leukemic condition. Again, the risk is low when patients get exposed to one round of chemotherapy. But as patients get exposed to more and more chemotherapy, then that risk actually increases a little bit over time. So in the past, when we didn't have any other options, we only had chemo. So there was not much that we could do for that. So you get chemo, and then 4 or 5 years later, you get chemo again, and every time you will chemo again. But now that we have so many other options and we can minimize that risk, my preference, and that could be, it depends on availability and patient and physician's preference and patient's preference. My preference will be if we use, a solid round of chemotherapy. My preference is not to repeat that unless it's absolutely necessary. So I'd rather move into a BTK inhibitor, a BCL2 inhibitor, or any of the trials that we have to try to avoid this excessive exposure to because of this potential problem.
There was a lot of discussion about T cells at the Ed Forum this year. And the question came up is, if someone does decide they're going to go on another round of chemo, should their T cells be tested before repeating it?
Yeah. Well, at this time, we don't have any data to support that should be done. There's some data that there are some chemotherapies that can affect T cell function. And I think the main reason to be, at least for the future, is that, I mentioned immunotherapies, right, bispecific antibodies and CAR T cells and all that. So all these new treatments that may be up and coming, I think for those treatments to work better, the patient's T cells should be in a better shape. And is chemotherapy now going to affect the T cell function in the future? I think that is a question that we are actually starting to investigate at this time. Some people feel that if you get exposed to chemotherapy today and your T cells will be affected because of that, that actually might recover over time, right? And therefore, if a few to several years pass by, then the T cells might not be as bad as they were when you were on chemo. So that will not be a reason to not to receive chemotherapy. While other physicians or scientists feel that, yeah, even though it was a distant exposure to chemotherapy, that still leaves you with some residual T cell dysfunction. And again, all these are questions that we don't have answers for at the moment. But given where the field of treatment for not only Waldenström, but for a lot of other lymphomas is going in terms of T cell engaging treatments, I think that's a very important question that we are going to have answers for in the near future.
Well, just one more question than that. Again, we see a lot. Is there any place for solo treatments with rituximab? And when do you feel it should be used?
Yeah, that's a good question. I think so. I do believe so. Overall, when we think about efficacy and depending on the goal of the treatments, if you compare combining chemotherapy with rituximab or giving patients BTK inhibitors, I would say probably 80 to 90% of the patients who get these treatments will benefit from these treatments in terms of feeling better. The rate of benefit with rituximab alone is much lower. It's about 60%. Again, but that doesn't mean that it doesn't work, right? It's just not as effective as other treatments. So if a patient can tolerate the treatments and they don't have any issues with the treatments, I think it's reasonable to choose a treatment that is likely to induce a higher likelihood of inducing a response. But I do use rituximab alone in some scenarios. There are some situations in which I don't feel the patient should be exposed to chemotherapy because of other potential problems or reasons, or I feel the patients might not be a good candidate for a BTK inhibitor, and sometimes I use rituximab in that setting. The other setting which I use it a lot is when patients who were exposed in the past to rituximab alone and the disease responded very well to that. So if I know that the patient's disease responds very well to rituximab, it's reasonable to try it again, right? So again, my sense is there is a role, probably a smaller group of people is the group of people that I will choose to get exposed to rituximab as a single agent, but definitely something that is still pretty much used, in clinic.
Thank you so much, Dr. Castillo. I am going to turn this over to Sharon P. and let her begin.
Hi, Dr. Castillo. Thank you so much for being here today. I'm Sharon Piotrowski. I'm a support group leader, a lifeline volunteer. I participate in the wellness program, and you used to be my doctor, but I went to your twin now at Dana-Farber, Dr. Sarosik, who is equally as great. So we're back to the fireside chat. Beyond your professional life, do you have a hobby or passion that helps you recharge or give you a different perspective?
Well, yeah, and otherwise I wouldn't be able to, exist. So yes, I do enjoy playing tennis and swimming and biking and hiking. And thankfully, all those activities, I share the same interest with my wife and my kids. So we're all swimmers and tennis players and bikers and hikers. So I think it's a nice thing to do, as a family. What I can tell you is these doubles tennis games are getting very competitive now that my kids are 14 and 12. And they're hitting harder, and and they know exactly where to put the ball, so it makes me look bad. Anyway, it is a great activity, and that really helps me a lot. The other activity that I enjoy greatly is to cook. I'm Peruvian, and again, Peruvian cuisine has had a moment now for almost a decade, if not longer than that. But and I grew up in Mexico, so I whenever I have the time, I take the time to cook a meal for my family, and so far they have not complained.
Oh, maybe you'll cook a meal for us one day. All right. Through the IWMF, we often learn about new treatments long before they're generally available. Can you describe a typical time frame from development to availability for the general patient population?
Yeah, that's a good question. And unfortunately, I don't think I have a very good understanding of exactly, to provide, really exact assessments for a number of reasons. Number one, it depends on the design of the study. We do have studies that we complete enrollment within a year and it's quick. And we do have studies that has been 3-4 years in the making, and we have not completed enrollment yet. And that has to do, because of the type of medication it is, has to do because of the scheduling of it, has to do because of the indication that we're looking. For example, studies that are dedicated to smaller groups, like patients with neuropathy, for example, can be much harder to enroll that treatments for patients with Waldenstrom's in the front lines. Those are typical studies that are enrolled faster. So how long it takes to gather the data, it's a little bit of an issue. And second is the interest of the company, right, in continue developing the agent. We have a series of trials that have been labeled successful and published, and the companies decide that that is not in their best interest, and they do not promote it. So it doesn't become available later on. Or we do run trials, and the trials show that these specific treatments either do not work as well as we thought they were going to work, or have too much toxicity in patients with Waldenstrom's compared to other conditions. And for that reason, the agent does not become available. So there's a lot of moving pieces, let's put it this way. But in an ideal world, we think about a clinical trial. We usually start within a year of that thought, and that accrual takes about 2 years. And then the first report comes out a year later. And then at that time, the company likes the data and then submits it either to FDA or the NCCN approval, and then becomes available. So yeah, it's a few to several year endeavor in most cases.
Sounds very complicated. How do you see the prospects for a cure in the near or distant future?
Yeah. So I think tying up with a question that we had earlier, getting into the complete remission type of situation, we do believe we say we, it's just as a society of Waldenstrom specialists and also blood cancer specialists, we do believe that I think we can start dreaming about a potential cure once we get to complete remissions that are durable, right? So I think that is from our perspective the first step. And for example, with BTK inhibitors alone, we do not see a lot of complete remissions. The same with BCL2 inhibitors alone. And even when we use chemoimmunotherapy, the rate of complete remissions is in the single digits. So the newer clinical trials, and I said this is a clinical trial question, in new clinical trials, we're trying to induce deeper responses and hopefully try to get patients to what we call complete remissions first. And once we know that we can get there, and then we can learn how to get there, then it gets easier to deepen those responses, using rational combinations and approaches. It's very possible that we need to select the patients. They're going to be patients in whom their diseases are more amenable to treatment or some specific treatments compared to others. So I think what we're trying to do is in between the better selection of patients and the subtype of patients' diseases and the newer treatments, to try to get to these deeper responses. I think if we get there in a more reliable manner, I think we'll be one step closer to start talking about a cure.
Gotcha. And I assume reliable data is more and more people are sustaining at whatever level you see as.
That's exactly the point, right? So yeah, it's people getting there and staying there, right?
Gotcha. I'm going to actually go one question that Sharon wasn't able to ask, because I think it's important, and it comes up on our Facebook page. And it is, for patients diagnosed with Bing-Neal syndrome who are asymptomatic after treatment, what surveillance testing is recommended and how often? And are all BTK inhibitors, including non-covalent, good for treating Bing-Neal? And that came up today on our Facebook page.
Yeah. All right. So Bing-Neal syndrome is this condition in which Waldenstrom cells gain access to the brain and the spine, and so cross into this blood-brain barrier. Actually, there is a physical barrier to trying to protect the spine and the brain from other things, other toxins, and obviously that protects against cancer cells as well. So in a few patients, I would say maybe 1% to 2% of patients with Waldenstrom's, the malignant cells gain access into the brain and the spine, causing this condition called Bing-Neal syndrome. Now, the treatment of Bing-Neal syndrome also varies greatly between chemotherapy and BTK inhibitors. If you get treated with chemotherapy and there is resolution of the symptoms and all that, then at that time, patients can stop therapy and patients can be monitored. In the patients are on BTK inhibitors treatments are indefinite. So patients should continue on BTK inhibitors for as long as the treatment controls the disease. So it's a little bit of a difference between what to do in one setting versus the other. So bottom line, we should treat Bing-Neill syndrome very much like another manifestation of Waldenstrom's macroglobulinemia. I think what a lot of physicians feel is that a patient has Bing-Neill syndrome, that's very much like a primary aggressive, brain lymphoma, which is not exactly the same thing. So the goal for a primary aggressive lymphoma is to remove all the malignant cells from the brain and clean the spinal fluid and be very aggressive about that. In Bing-Neill syndrome, it's just a little bit different because Waldenstrom's is different, right? This is not the classic aggressive lymphoma that we tend to see in the brain. So once we control the symptoms, the patients could be observed, off therapy if the patients receive a finite treatment. And that could be done every 3 months with labs and physical examination, maybe every 6 months with MRIs and things like that, if there were any abnormalities in the MRI in the first place. And I typically do not recommend monitoring with spinal fluid. And I want to tell you that why in a second. And with BTK inhibitors, the same. If the BTK inhibitors improve the patient's symptoms, then the patients could continue being seen quarterly, MRIs every 6 months or a year. And again, not necessarily with spinal fluid testing. Why? Because in the studies that we have done, and we have a few now in Bing-Neill syndrome, despite the rarity, there is always a little bit of cells left behind in the spinal fluid. And that makes sense, right? Because if you treat systemic Waldenstrom's and you still have residual disease when you're treating Waldenstrom's in the patient's body, what would the brain be different, right? So we also treat the brain, the Waldenstrom's in the brain, and will still be a little bit of disease left behind. And that should not be a reason to consider a treatment a failure because the spinal fluid is not clean. Also, the patients feel better and the MRIs look better, for example, right? So for that reason, we prefer not to, be doing lumbar punctures on patients all the time just to check on the spinal fluids. So the monitoring, from my perspective, is quarterly, MRIs every 6 to 12 months, no spinal fluid testing, and then we'll go by the patient's symptoms. If and when the patient's symptoms do relapse, at that time makes sense to re-evaluate everything again, from imaging to spinal taps and things like that, but not for monitoring purposes.
That was interesting too, when you said about why do the spinal tap, because you're still going to probably have some of the disease in there. Similar, why would you repeat maybe bone marrow biopsies even after treatment, because you're still going to have.
I think it's a very, we approach it in a very similar way.
Yeah, that makes sense. Okay, so let's ask about something that you're involved in. So there's the WMNet. Can you tell us a little bit about that, and are any new trials being added to it recently?
Yes, no, thanks. So WMNet has been around for a couple of years, and it is a consortium of about 25 centers in the country. And we have a series of projects that we're working on. I think the most important project are the running clinical trials in a concurrent manner. So at this time, we have 3 active trials that are being run. One of them is almost complete, which is the loncastuximab tesserating study. This is the study that Shayna Saroshik is running. We're 1 patient away from completing the accrual on that study. That study is open in Boston, is open in Rochester, Minnesota by the Mayo, and also in Seattle by the Fred Hutch. So there's 1 more person to participant to be enrolled, and we will complete the accrual for that study, and then obviously we'll continue the follow-up to see the long-term benefit of that intervention. On this project, we will have an oral presentation at the American Society of Hematology meeting in December. So it has been considered to be of high impact, and this is going to be the first WM network presentation at ASH in one of our clinical trials. So I think that's a very nice thing to have. The second study that we have is one that is combining actually BTK inhibitors and chemotherapy for patients who have never been treated. It's called the ZEBRA study. ZEBRA, very appropriate. So that study is actually halfway enrolled. We're actually more than 3/5 enrolled, and that is run in Boston, and is also run in Denver, Colorado by the Colorado Blood Cancer Institute, and about to open in Dallas at the UT Southwestern. And there's one study that just opened with epcoritamab, which is a bispecific antibody. It's the first trial with a bispecific in the world for Waldenstrom's is through the network. And that is open here in Boston and will open in at University of North Carolina and also in Dallas at UT Southwestern. That is, we just have a few patients entering that clinical trial at this time. We have 2 other trials that are undergoing developments, and they will follow. So the idea is to complete one trial and to open the next. So we have 2 more on the way, really well advanced, well designed, and that's also going to be having. We're going to have Sloan Kettering in the Mayo Clinic and other centers involved in these trials. So yeah, it's an active process, and hopefully this will continue, with the support of the foundation and the patients who will come and participate in clinical trials. The second project is the database project. We're trying to get a 10-year snapshot of how we treat patients with Waldenstrom's in the United States. I don't think we have a database to actually show that with granularity. And when I say granularity, I mean, dates of diagnosis, dates on when you started, what type of treatment you got, what type of data, laboratory data you had, the responses. So this type of data does not exist at this time for Waldenstrom's in the United States, right? So either we have the medical database, which is more like, claims or epidemiological data, which doesn't really have treatments very much well delineated. So I think there's going to be an important gap to be filled, with this project specifically. And if it's true that with clinical trials, the participation is, 5, 6, 7 centers, maybe a dozen of centers. For the database, pretty much every center is interested in providing the data. So there will be a good snapshot out of 25 centers in the country in the last 10 years. So that is something that we're about to start. And I think we will be hearing very soon on what we learned from this, over the next year.
Wow, thank you so much for your involvement and all that. And just hearing you in last May, it sounds like you've had much more involvement since then and more trials coming up. So congratulations.
Yes, that's true. No, that's true. Exactly. No, he's taking,
All right.
there's a momentum. So that's great.
That is great. A question that somebody just posed to me, if I can find it real quick. And no, of course, Lisa, I can't find it. So I'm going to move on. Actually, I think this is the question. What's the one thing that you would want every WM patient to know while they're on this journey? The one thing or 2.
Yeah. So I mean, after seeing probably thousands of patients with Waldenstrom's in our clinic, I think, and I kind of alluded to a bit about this during this hour. I think it's important to be educated, but also be careful, right? Because there's a lot of material out there that is not precisely validated, and to be careful about that. I think the foundation provides good, reviewed, vetted, valid data in their websites in terms of treatment options and what the patients can, should use and not use. So I think educating yourself about your own disease, it's important. The second one is, being your own best advocate, right? I mean, how your disease behaves, how you react to treatments. Nobody knows that more than you, right? So you should surround yourself by nursing staff, by physicians and others who will be there to support that, throughout the way. So I think having your family and loved ones involved in your care and understanding you as well is key. And, really participate as much as possible, in the support groups, because I think the worst thing that a patient with a rare disease can go through is to go through it alone, right? So knowing that there are other people that go through this, and you can count on, and they can provide you with some previous experience and, importantly, hope, of the future. I think that's key. I would say, just to finalize, is we are working really hard, and when I say we, it's just me and everybody else in the Waldenstrom's community, in the research community, to try to come up with newer treatments, better treatments, hopefully deeper responses that will last longer. And if we can get to this cure that we are all dreaming about, then that'll be an amazing thing.
Wow, thank you so much for everything you've said. I think the key here is that we just really do have to be our best advocate and look for the future for future treatments and hopefully a cure. So thank you, Dr. Castillo, for your time today, joining us for our first ever Waldenstrom's Unplugged conversation. For our attendees, although our time with Dr. Castillo has ended, please don't go anywhere. We are now going to move into the support group breakout session part of the program for the next hour. When you registered for the meeting, you selected your local regional or affinity group. In a moment, we will open the breakout rooms for you to join your selected group. Since this is our first time piloting this meeting format, please be patient in case there's any glitches. If you happen to be in the incorrect group, please enjoy your time because we can't move you. The meeting will close at 4 p.m. Eastern Time. We want to thank you for joining us today and hope you enjoyed this new meeting format. And again, a round of applause for Dr. Castillo. Thank you so very much.
Thank you very much for having me. It was really an amazing opportunity, and I wish you do this much more often.
In front of her fireplace.
Yeah, that would be amazing.
Enjoy the rest of your day, and thank you again.
Thank you. Very good to see you all.